If you've been through IVF, you've probably heard the term PGT testing. And if you got back results that said abnormal or worse, that one of your embryos is mosaic, you may have been told to set it aside, maybe even to discard it. I want to talk to you about that exact thing today. Because in my 24 years of working with women and couples navigating fertility, this is one of the most misunderstood and honestly, one of the most painful moments in the IVF journey. You go through the retrievals, you watch your embryos develop, you're counting them, and then the lab comes back with a report that categorizes one of them as something less than normal. And suddenly you're being asked to make a decision about an embryo that might be your baby. Here's what I want you to know before we dive in. The science around mosaic embryos has evolved significantly in recent years, and most of what patients are being told at their clinics, it hasn't kept up. In this video, I'm going to walk you through what PGT testing actually measures, what it misses, what mosaicism really means for your chances, and what you can do to give that embryo or your next embryo the best possible environment to become your baby. And if you're new here, hi, I'm Dr. Marc Sklar, the fertility expert. I spent over 2 decades helping women find the root causes behind their fertility struggles and build a real personalized plan to move forward. We've helped thousands of couples, many of whom were told their situation was hopeless. We've helped them finally bring home a healthy baby. Before we get started today, I want to make sure you have something after this video. I've put together a free training for you. If you've been wondering, what is going on? Why can't I get pregnant? What can I do differently to finally get pregnant or hold a pregnancy? I put together a free training called Why You Are Still Not Pregnant. It's based on 24 years of working with women just like you, and it gives you a clear, actionable starting point, no matter where you are in your journey right now. You can grab that in the description below. This is the foundation of what we do with every single member inside our program, and you can start implementing that today. All right, let's get into it. What does PGT testing actually tell you, and what doesn't it tell you? PGT-A stands for pre-implantation genetic testing for aneuploidies. That's a long name for a test that checks whether an embryo has the right number of chromosomes. A typical human embryo should have 46 chromosomes, 23 from mom, 23 from dad. When a PGT report comes back, it typically puts embryos into one of 3 categories. Euploid, meaning the right number of chromosomes and cleared for transfer. Aneuploid, meaning an abnormal number that's generally considered non-viable. Or mosaic, which is where things get complicated and where I want to spend real time today. Here's what most people don't realize. PGT-A is not a perfect test. It's a biopsy. A few cells are removed from the outer layer of the embryo and then tested. But here's the thing, those cells become the placenta, not the baby itself. The inner cell mass, the part that becomes your child, it's not directly tested. So what you're actually getting is a sample of the embryo tested from cells that are destined to become the placenta. This means false positives happen. An embryo flagged as abnormal based on those cells may actually have a perfectly healthy inner cell mass. There's published research, and I'll come back to this, showing that mosaic embryos are producing healthy, chromosomally normal babies. So what does this mean for you? It means that PGT result is information, not a verdict. It's one data point. It should be weighed alongside your full clinical picture, your body's preparation, your history. That's the difference between a clinic that treats you like a number and a program that treats you like a whole person. Inside the HOPE program, the first thing we do is an in-depth assessment, what we call the assess phase. We look at your full fertility picture. PGT results, yes, but also your hormone panel, your immune markers, your gut health, your inflammatory status. Because an embryo, even a mosaic one, doesn't implant in a vacuum. It implants into your body, and your body's environment matters enormously. So what is mosaicism really? Let's demystify the word mosaic because it sounds terrifying and it doesn't need to be. A mosaic embryo is one where some cells have an abnormal number of chromosomes and some cells are normal. Think of it literally like a mosaic tile pattern. Some tiles are one color, some are another. It's not uniformly abnormal, it's mixed. Now, here's the key question. Does mosaicism automatically mean that the embryo can't develop into a healthy baby? The answer, based on current evidence, is no. Not automatically, not even close. Research published in journals like Fertility and Sterility and data from labs like PGT Specialists and PGDIS have shown that mosaic embryos do successfully implant, do carry to term, and do produce chromosomally normal babies. There's even a phenomenon called self-correction, where abnormal cells are naturally selected out during the development and the embryo normalizes itself. The degree of mosaicism matters. A low-level mosaic embryo, let's say 20 to 40% abnormal cells, has a significantly better prognosis than a high-level mosaic. The specific chromosomes involved matter too. Some chromosomal abnormalities are associated with conditions that are survivable and compatible with life. Others may not be. I've had members in the HOPE program who came to me with mosaic embryos that their clinics had essentially pushed to the back of the shelf. One of them, I'm thinking of her right now, had 2 euploid transfers that failed. She still had a mosaic embryo. Her clinic was hesitant to transfer it. We worked together for several months on her uterine environment, her immune system, her inflammatory markers. She transferred that mosaic embryo and she is now a mother. That's not an anomaly. That's what happens when you prepare the body, not just classify the embryo. So why do clinics default to discarding, and why is that potentially outdated? I want to be fair to reproductive endocrinologists. They are working with the tools and protocols they have. And for a long time, the guidance was if an embryo is mosaic, the risk is uncertain, so do not transfer it. But the science has moved. It's changed, and for many clinics, the protocols have not. Here's the reality of what often happens. A clinic's success rate is measured by the live births per transfer. If they don't transfer a mosaic embryo, they don't risk a lower number. There's a very real financial and statistical incentive to be conservative with mosaic transfers, even if it's not what's best for you. I'm not saying clinics are acting in bad faith, but I am saying that if you have a mosaic embryo and your clinic immediately tells you it's not transferable, you deserve a second opinion. You deserve a conversation that includes the current literature, the degree of mosaicism, the specific chromosomes involved, and most importantly, what's happening in your body that might affect implantation either way. I had a group call recently where a member named Lena raised the exact question. She had a frozen mosaic embryo from a previous cycle, 2 options on the table, and her clinic wasn't giving her clear answers. What came out of that conversation was what always comes out of this type of work. Clarity for her. Once we understood her full picture, her hormones, her husband's morphology, her cycle health, she had a real roadmap, not guesswork. That's what you need, not just a category on a lab report. A roadmap. If you're sitting with a mosaic embryo right now, or if you've had failed transfers and you're not sure where to turn, I want to invite you to book a fertility assessment discovery call with my team. We want to review your case and help you understand what's actually going on and whether the HOPE program is the right fit for you and your next steps. The link to apply is in the description below. The 4th point I want to make for you is that the body is only half the equation. Here's something that gets almost no attention in the conventional IVF world. The uterine environment is not passive. It's not just a container waiting for an embryo to show up. Implantation is an immunological event. Your immune system has to recognize the embryo, tolerate it, and support it. When that process is dysregulated because of inflammation, autoimmune reactivity, poor gut health, nutrient deficiencies, or thyroid dysfunction, even a genetically perfect embryo can fail to implant. Think about that. Euploid embryos fail all the time. Amanda came to us after 3 failed transfers with PGT-A tested euploid embryos. 3. She was 40, she had 2 embryos left, and her clinic's answer was, let's try hysteroscopy and then do another transfer. There was no conversation about why 3 euploid embryos had failed. No investigation into her immune environment, her microbiome, her thyroid, nothing. That's the gap, and it's a significant one. When we talk about preparing the body for a mosaic embryo transfer, or any transfer for that matter, we're looking at things like inflammatory markers like CRP and cytokines, thyroid function, not just TSH, but T3, T4, antibodies, the uterine microbiome, natural killer cells, progesterone levels and luteal phase adequacy, nutritional status, CoQ10, vitamin D, omegas, antioxidants. These are the pieces that determine whether an embryo, mosaic or euploid, has a real chance. And here's the thing I tell every member who comes into our program. The embryo is only half the equation. Your body is the other half. And your body is something we can work with. So when should you consider transferring a mosaic embryo? Well, I'm glad you asked. Let me give you some practical guidance here because I know that's what you are specifically looking for. And that's what I would be looking for. A mosaic embryo transfer may be appropriate when, number 1, it's your only or last embryo. If discarding it means you have nothing left, the risk-benefit calculation changes dramatically. You should have a serious data-driven conversation with your doctor, your provider, about transferring it. Number 2, it's a low-level mosaic. Under 40 to 50% mosaicism is generally considered more favorable. Ask your clinic to give you the exact percentage, not just the label. Number 3, the chromosome involved is not associated with a serious non-viable conditions. Mosaic trisomies of certain chromosomes like 21 in Down syndrome have actually resulted in live births. Others are less survivable. Know the specifics. Number 4, your uterine environment has been optimized. This is where the work we do in the HOPE program is critical. Before transferring anything, euploid or mosaic, we want to know that your lining is healthy, your immune environment is regulated, your inflammation is controlled, and your hormones are balanced. Number 5, you've had a failed euploid transfer. If chromosomally normal embryos haven't worked, the problem isn't the embryo's genetics. It's something in the environment. And that means you need to address the environment before any transfer, regardless of whether the next embryo is euploid or mosaic. Inside the HOPE program, we use a 3-phase approach. We assess, getting a full root cause picture of what's blocking pregnancy. We personalize, building a specific protocol for your body and your situation. And we support walking with you every step of the way through the process, from pre-transfer preparation through the 2-week wait and beyond. This is not a one-size-fits-all approach. It's built around you. Here's what I want you to leave this video with. A mosaic embryo is not a failed embryo. It is an embryo whose potential depends significantly on 2 things: the degree and type of mosaicism, and the body it's being transferred into. The first thing is something you can understand and get clarity on by asking better questions at your clinic. The second thing, that's something we can help you build. The women who come into the HOPE program after failed transfers, whether they had a euploid embryo or a mosaic one, share something in common. They were only getting half the picture, the genetics half, and nobody had helped them optimize the other half, which is their own body, your body. Sandrine came to me after 3 miscarriages and 3 failed IVF cycles. We worked together, she miscarried again, and I told her not to give up. She didn't, and on October 26, 2018, she welcomed her son Esteban. 9 months later, she was pregnant again. She was 41. She had endometriosis and antiphospholipid syndrome, and she is a mother twice over. The system we've built inside the HOPE program, the Assess, Personalize, Support framework, it exists because fertility is not a single variable problem. It's a full body, full life investigation. And when you do it right, things change. If this resonates with you, if you're sitting with a mosaic embryo or a failed transfer or a diagnosis you've been told to accept, I want you to take the next step. Apply for a fertility assessment discovery call with my team. We'll sit down with one of our specialists, walk through your full history and test results, and leave with clarity on what's actually going on and what your real options are. The link to apply is in the description below. This is your next step. Take it. Now, if this video has you thinking about what else might be happening in your body that you're not seeing, I want you to watch this next one. It's called Signs You're Losing Fertility and How to Fight Back. I walk through the physical signals that most women miss until it's too late, and more importantly, what to do about each one. It's one of the most important videos on this channel. I'll put it right here for you. Don't skip it. Until the next video, stay fertile and stay hopeful.